with Manipal University. And he has also provided voluntary service at the Isha Foundation in Tamil Nadu. And his main areas of interest are in healthcare system development, in the rural and also community-based palliative care service. And Dr. Deepak Sudhakaran is going to take us through our topic today. The floor is yours, Deepak. Go ahead.
Good evening, ma'am. Am I audible?
Yes.
Yeah.
Yes,
thank you so much, ma'am. I think there is some work going on here. Is it too much of a disturbance, ma'am? Are you hearing any disturbance?
No, we are okay.
All right, great. Okay. So good evening to one and all. First of all, I would like to welcome all the esteemed faculty over here, joining us from different parts of the country. If the participants who are there here, if you could just give me a thumbs up or an okay sign if all of you are having the audible, I'm audible, it's clear. Is any disturbance you are hearing from our side? It would be good for me to know. And also a thumbs up for if the slide is visible now. I can see 2 thumbs ups, 3. Yeah. So I know all of us are busy and all of us are, at different phases of service delivery and careers and everything in our lives. But as far as this session is concerned, I would really appreciate it if this is a two-way session. That is, there is continuous interaction between us, mostly through the chat box. But if not through the chat box, whenever you wish to speak up, when a question is asked, you may please feel free to unmute yourself after you raise your hand. So I think today's session will be pretty basic. Many of the things you may be already knowing. But however, we need to walk through certain things. So we'll go through that together. And I would really appreciate it if more people turn on their videos. I can hardly see 10 people who have turned on their videos. It would be good if more people turn on the videos so that I'm able to see all of you on the same screen. It would be good to see your facial expressions as well. And also to know whom all I'm putting off to sleep early in the evening. All right. So please do actively participate through the chat box. And whenever you wish to speak up, do raise your hand as well. What comes to your mind on looking at this picture? There is a picture which you are able to see on screen. What comes to mind? Can you share in a few words or in a few, just keep putting the words. One word which comes to your mind on the chat box, please. When you see this image, what is coming to your mind? Dr. Mercy, pain, a disturbed mind, agony. Can we put the chat box on the screen? Thank you. Depressed, mental stress, tears, suffering, desperation, depressed, stress, brainstorming, pain, sadness, suffering, sadness and agony, stress, suffering, pain and suffering. Yes. So I think all of us are using synonyms, different words for the same emotion or feeling which the person is going through. Can we minimize the chat box, please? Now, how many of us think that a patient who comes to us is actually going through these things and not the disease? How many of us consider that a patient is going through pain, going through suffering, going through depression? There is a whole storm happening inside the mind of this person. Do we actually think that? A yes or a no? I just want a very frank, between you and me, an answer. How often? Most patients, yes. let's be very frank. I studied in a medical college where we had a good number of patients, which you know how it is. When the patient load starts going up, the amount of time we are able to spend with each patient goes down. With that, how much of a justice are we able to say that we are able to do for the patient? Can we have the chat box, please? Come up, come up. Yes, yes, no. Most of the time, no. Go up. No, yes, yes, no. Most of the time. All right. Minimize. You know, there is a study which found that once a patient starts talking, you know, when does the doctor interrupt? How many seconds or minutes, according to you, does the doctor listen before the doctor starts talking? Again, the chat box, please. Just a random guess. It may be in seconds or minutes, however you feel. Okay, Dr. Meera, 30 seconds. Dr. Shweta, question mark, 2 minutes. Come on, more guesses. Maybe 15 to 20 seconds, 5 minutes. Okay. Dr. Gurinder Kaur, can you tell me what specialty do you practice or what field of medicine are you practicing? 20 seconds, 1 minute, 10 minutes, less than a minute. 20 seconds. All right. Thank you for your responses. Minimize, please. So the study found that on a median of 11 seconds, 11 seconds is all it takes for a doctor to interrupt. I want to know from you that if you are a patient and if you go to a doctor, how much can you explain yourself or your issues in 11 seconds? Yes, this is food for thought, right? So this is the reality which we are living in. Let's all agree to it that we all work in very high burden situations where there are maybe tens of or hundreds of patients depending on the settings you are working in. And how much of justice can we really do? Most of the time we look at the disease, but to know the person it takes, I'm sure, more than 11 seconds, right? Yes, I agree. Patients wait 2 to 5 hours and doctor sees them for 2 to 5 minutes in total, right? So with that, let's get introduced to what pain means to a person. So what does pain mean to you before that? What do you mean by when you say that I am in pain? What does it mean to you? Is there a definition for you? Or what is the feeling which you go through? Is there a sensation what you go through? Okay, Dr. Gurinder Kaur. Physical pain. Pain means physical pain to you. Yes. I'm looking for more responses. Discomfort. All right. Bring it onto the screen, please. Yeah, that's good. Suffering, strong discomfort, limiting my daily activities. Yes. Physical, mental pain and discomfort. Yes. Both physical and mental discomfort, agony, not able to do day-to-day work, both physical and mental stress, discomfort, something that can't be bared by an individual, something that patient feels out of normal, is nociceptive and cannot suffer or suffers a great deal of disability, discomfort in daily activity. So when we are in pain, many of you have said that we are not able to do our activities of daily living. And that is why we want pain medications, or we want to ease our pain so that we can do what we are supposed to do, right? What about this guy? You think this guy is in pain? Again, your responses, please. This guy is voluntarily doing something due to whatever reason. Okay, he's enjoying pain. There is no pain. There is yes, there is pain. There is tolerable pain. I don't know if I'll be able to tolerate that. Yes and no. Okay, mixed bag of feelings. Controlling the pain. Okay, he's in pain, but his pain is subjective. Dr. Henson Henry. Purpose may diminish the idea of pain. All right. minimize it. So we all are coming to a term of a sense of agreement that there are various factors which can influence pain, right? It is not always just the physical stimulus which is there. Many a times there are different aspects of pain which can influence the intensity of pain. Last week, when I was in Delhi, I had gone to Delhi for some purpose. I got injured on the road. I had walked 8 kilometers. Okay. I had 2 more kilometers to go. I was able to continue walking. Is it because pain was not there or the injury was not there? It was there, but there was something else within me because of which I was able to drive myself till the time I reached my room, and then the pain really started happening when I stopped moving around. So there are many aspects to pain. It is not just always the stimulus. There are various dimensions to pain which influences it and influences our capacity to go through it. Do we agree till now? Yes, the chat box, please. Do we agree till now? At least we have reached to a place where we understand that it is beyond physical. It's not always physical yet. Okay, all right. So then what is pain? Yes, there is a definition for it. An unpleasant sensory and emotional experience associated with or resembling that associated with actual or potential tissue damage. Can we have the chat box here? Yeah, on this side, yeah. So there is a definition for it, right? It's definitely an unpleasant sensory and emotional experience. Have you seen when we reach home after a long day of work and we are having a headache? And if somebody in our house is not doing things according to the way we want them to, does our headache increase? Yes, headache increases. It becomes unpleasant. And does it become an emotional experience also? Why do I have a family member like this? Never understands me, right? Something which all of us often go through. So yes, there is an emotional experience also associated with it. And there may be actual or potential tissue damage associated with it, right? But as far as palliative care is concerned, I'm going to introduce something to you. We are going to believe what the patient says, which means pain is when the patient says that it hurts, and that's about it. You know, many a times we see during our rounds, we discuss, according to the issue which he has, it is not possible that he has this much pain. So let us not give him the pain medication. This is sometimes which, like when during my undergraduate days, we have heard it, and then I have also agreed. But now coming into this field, I realized that many a times there are so many factors which influences pain that the tissue damage may be small, but the pain may be unbearable. And how many times do we actually explore? How many times do we ask, why is it that it's paining for you this much? Is there something else which is bothering you? Is one question which we have to start asking. So why is pain control important? So one thing is physical pain is the most common. Even here, when I asked about pain, the first response was physical pain. So physical pain is the most common feared and debilitating experience. After my injury, I was very scared to move my toe. I was extremely careful of it, making sure that I don't even accidentally bump into it, to the extent that it disturbed my sleep also, because the bed sheet was rubbing against it. So I had covered it from all sides, making sure that it is protected, because there is no skin anymore, right? It's just raw surface. So very feared, common, debilitating experience. And patients with palliative care are usually those with life-limiting illnesses or terminal illnesses. That is, there is no cure for it. Many times it is a progressive disease. So the pain keeps worsening over a period of time. It's a constant reminder of the illness. Of course, changes in pain may indicate progression of a disease. And it prevents all of us from doing what we are supposed to do in life and finding meaning in life. So what about, if the suppose there is a stimulus of pain in the body, somewhere in the body, but the stimulus is continuous. What happens? Does the pain increase or decrease? Can we have responses on the chat box, please? If there is a continuous stimulus which causes pain, what happens to the experience of pain? Does it increase? Does it decrease? Is it the same? Okay, increase. Like, when we wear clothes, after some time, we are not aware of whether we wear the clothes or not, right? Some amount of sensitization which happens. So what is happening to pain as far as pain is concerned? The threshold of pain keeps increasing, seems to decrease as the threshold increases, decrease, increase, constant. Okay, we are getting big bag of responses. So what does pain indicate? Pain indicates that, all right, constant. The pain remains the same. Okay, let's look at it this way. At a very basic level, when you have pain at some site of the body, what is the body trying to tell you? Is it seeking for attention? Let's look at kids at home. They want something. They're going to come and ask you once, can you give me this chocolate? And then you're not paying attention to it. You don't pay attention to them. What happens after that? Yes, responses, please. A child is asking you for chocolate. He asked once and twice, and you're not paying attention to the child. What will the child do after that if you don't pay attention to him? Yes, child cries, child shouts, usually cry. Basically, he's going to make hell out of you, right? He's going to make sure that you get your attention. Tries to grasp attention. Yes, Dr. Kannan. Might become restless, irritable. Yes. So this is what pain will also do, because pain is begging for your attention in some part of your body where there is an issue. Now you are not paying attention to it. What will it do? It releases certain inflammatory mediators. Once the inflammatory mediators are released, whoever is there nearby, all the nearby nerve endings which is there, will start getting activated. It is just like a child getting more and more irritable. And then it will start grabbing your attention even more. Oh my God, the pain has increased. And now you are forced to pay attention to it. Now, this is going to happen at a peripheral level where the peripheral nerves start getting sensitized and recruited to cause more pain. This will also happen at the spinal cord level, at a central level, where the issue may be localized, but when the person talks to you, he will say, my whole body is paining. And then when you look at the situation, the pathology of it, it is only there at one place, but the patient is saying whole body pain. So this is not making sense. And then we come to the conclusion that probably there is not that much pain. Let me just give him a mild amount of, a mild dose of painkiller. That should be enough. So what we need to understand is there is definitely a small stimulus can lead to something as extended as the whole body pain also. And we will believe the patient when he says so, right? Because mechanism of pain is different. The way it sensitizes and recruits the other nerve is different. So what are the types of pain? Yes, doctors, can you type on the chat box types of pain according to you? So here we can see at the level of the receptors, at the level where the things start, it is called as a nociceptive pain. And then if the pathway is affected, it is called a neuropathic pain because it is along the nerve root. So let's look at it. Nociceptive pain itself can be somatic and visceral. In somatic pain, there is stimulation of peripheral receptors. Now, these peripheral receptors are basically whatever is there on the outside. That is the skin, the muscle. You come deeper if there is bone pain, bone-related pathologies, and then connective tissue. These are all somatic nociceptive pain. Usually for this kind of pain, the person can clearly localize where this pain is. Because there is a tissue over there and there is a damage over there, he can clearly localize and tell this is where the pain is, this is where it started. After starting from here, then it spread. Described in different ways, it is sometimes called as an aching pain. We'll look at the different descriptions of pain later. And it responds to simple analgesics, or sometimes opioids may also have to be given. What about visceral pain? Visceral would mean that it is there inside the viscera. Somewhere inside it is there. The patient is not able to clearly tell with a pointed finger that it is here, it is there. He is not able to tell clearly sometimes. So this happens when there is an infiltration, compression, distension of thoracic or abdominal organs. So for example, if we take cancer as an example, it's there in the colon or it's there in the liver or different part of the abdominal organ. Sometimes we are not able to, many a times they won't be able to localize it. It's just an abdominal pain probably. They'll just hold their hands over their abdomen and sit. So these are the mechanisms: infiltration, compression, distension. These are the different mechanisms through which visceral pain is generated. Vaguely localized, vague localization. Different ways to describe it. It is a deep pain. It is a squeezing type of a pain. I feel there is some pressure inside. I feel discomfort. I feel that my insides are sore. There is a deep aching pain, etc. And this may cause referred pain also. That is, the pathology is somewhere, but the pain is somewhere else. Often associated with nausea and vomiting. And these kind of pains are very, very opioid sensitive. So neuropathic pain is a constant pain. Sometimes, most of the time it is constant, but there can be something called as breakthrough pains also, which we'll look at later. There is abnormal sensations, right? Very commonly we hear whenever there is a nerve involved, I feel tingling sensation, or I feel like pins are being, pins and needles sensation. Or very common description is, I feel that red chili powder, a paste of red chili powder is being applied on my foot. Okay. Then there is something called as allodynia, where pain from a stimulus, it should not normally cause pain, but in this situation, it is causing severe pain. For example, the person can't even use a bed sheet for covering themselves at night, because if the bed sheet touches their skin, they feel severe pain. So it is called allodynia. It's a kind of neuropathic pain. And then commonly what we hear is shooting pain, sharp kind of pain, lancinating. I feel like an electric current is passing through my leg. And it usually has a clear nerve. Wherever is the nerve distribution, accordingly the pain will be in that distribution, that area of distribution. What about people who can't express pain? How will they, due to some pathology or due to old age, in impaired old people or people who have cognitive impairment, can they express pain? So people who are taking notes, I can share the slides with you. That's not an issue. So yes, even in them, for people who are not able to express it, or people in whom cognitive impairment is there are different ways in which you can find out whether they have pain or not. For example, in children, in pediatrics, in children, mostly the children will cry or not allow you to touch a certain body part. In adults, there will be changes in facial expressions. They will be making some sounds or vocalization. They may have certain kinds of body movements, or there must be restriction of body movements. They may have behavioral changes where they may act aggressively or irritably. And they may have changes in routine, like, they don't want to have food anymore, or, their sleep pattern is changed, etc. And of course, it leads to mental status change also. For example, delirium, there will be a session on delirium later on. Uncontrolled pain can also lead to abnormal behavior, with the pain being the stimulus, uncontrolled pain being a being a cause for it. So yes, in people who cannot express, or in people whom we cannot comprehend well, they also express pain in different ways. With this, we'll come to the story of a patient who was there with us. Let's call him Mr. A. He was diagnosed with a head and neck cancer, and he was on treatment from a tertiary care center, which is a disease modifying treatment. That is, he was on curative therapy. He has a wife and 3 children, and his elderly mother is staying with him. Now, this is an actual photo. This is his actual photo. He came to us with severe facial pain. Facial pain so severe that he was not able to sleep for months. But the treatment is continuing at the cancer hospital. So he was referred to us for the pain. Now, what do you think will be going through this person's mind? This person comes to you, he's sitting like this. This is his family background. Use your imagination. If such a person comes to you, what is it that will be going through his mind? Can you share? There is agony. He feels guilty. Yes, Dr. Kannan, why do you think he feels guilty? Can you unmute yourself and share with us? There is hopelessness. There is want to get rid of pain. Yes, there is definitely want to get rid of pain. Dr. Kannan, interesting.
Yeah.
Guilty. Yeah. Yes, please.
Maybe because of tobacco use, he might have some idea that because of his habit, he received
Okay.
his
Okay.
cancer.
All right. All right. Thank you so much. So because of
Yes, yes.
he's thinking, he's associating it with a habit he may have had.
Yeah.
He may not want to continue to live. He feels like he's becoming nothing. There is insecurity, desperate to get relief from pain. There is hopelessness. He gets depressed, insecure and depressed, wants pain to disappear, wants to sleep. So we did a little bit of exploration with him. Yes, emotional disturbance due to insecurity. Let's look at what all he was thinking. Will I be able to pay my medical bills? How will I provide for my family? He was the only breadwinner, and of course, he was doing some menial job. I don't want to eat or talk to anyone anymore. There is just too much unbearable pain. He is not able to sleep for months together. He wants to catch some sleep, but he is unable to. Am I going to die now? These were just some of the things which he was thinking of. Of course, this took more than 11 seconds of exploration to do. But these were the things which people think of when they come and sit in front of us with a disease. And what do you think, according to you? Only if a person has got some grave disease like cancer, do they think these things? Opinions? 65, more than 65% of our country is still below poverty line. No, no. So any disease a person is having, of course, some of us, if we know the disease well enough, we're educated enough, sometimes it's different, our approaches are different. But usually, very usually, if a person is having a disease, there is an element of uncertainty. What is going to happen? Are things going to be okay? How is it going to proceed? Do I have to continue taking these medications for the rest of my life? Oh my God, in a month it takes this much amount of money. Where am I going to get the money? I'm hardly able to afford new clothes for my children. I'm not able to buy things for my children when they demand it. How am I going to manage all these things? Today I went to the government medical college over here some time ago, like half an hour before coming for the session. I saw one lady who was asking, do I have to pay for this? There is a long queue. They are coming from few kilometers away. They have to get into a public transport and go. She's worried if she's going to have enough money if she pays for the medication to go back home. These are the kind of questions which a common man is having in his mind. And how many of us think about those things and what we can do about it is a question which we have to ask ourselves. Let's proceed. So definitely this person has physical dimension to pain. There's a psychological dimension to pain. There are socioeconomic aspects to pain. And there is a spiritual dimension to pain. If you look at all of them together, this is what we call as total pain. So in essence, what I'm trying to tell you is illness-related pain is much more than just physical distress. It is much more than that. It reflects in many areas or in all areas of a person's life. So what are the influences on pain perception? Of course, there are other symptoms. Along with physical pain, suppose you develop a nausea and vomiting. Are you going to become more irritable and more? Is it going to worsen your experience of pain? Yes. Social issues, you're not having it, it's going to, if you're having a, you don't have a good equation at home many a times. Due to whatever reason, there are n number of reasons, especially in the lower socioeconomic strata. If you go, you will see so many reasons why these issues are there. This will reflect on the patient's disease also. Financial constraints, legal issues which they may have. A lot of issues like that, which has a bearing on pain. Cultural influences of pain, many a times certain religions say that you should not do certain things as treatment. Many a times there is a belief that this is God given, you have to go through it, so bear it. I mean, different kinds of perceptions, different influences regarding pain, regarding disease. So there is a lot of influences on pain. Spiritual distress, like how Dr. Kannan was saying, this person starts going into some sort of a guilt. God is punishing me because I used tobacco in my past. This is a very real issue. If you start talking to people, they start having a regret, they start having a fear, they start associating it with other things which they have done in their life, which they thought they shouldn't have done, and now they are being punished for it. So there is a lot of existential crisis in a person. And all these negativities is something which causes an influence on the pain. Majority of the times, it increases the pain. So let's come to how do you assess pain? So the first step is you have to build a relationship. Sometimes we may not have time, but if we have more than 11 seconds, we need to look at building a relationship. Where are you coming from? How did you come? Who has come along with you? Did you have lunch? Etc. etc. Certain relationship building questions. Listen actively before you interrupt. Convey that you care. Okay, I understand you are going through these things. I'm going to be with you through this. Let's see what we can do. Promise to do your best, but do not promise that you're going to make everything right. Many a times when we say, even when we know things may not looking positive. Right now, there is a 28-year-old, he's having cholangiocarcinoma. And he's still taking treatment. He comes every 2 days to get an ascitic tab done. Almost every 2 days. Sometimes daily also. Because his abdomen gets filled, he gets breathless, he's not able to lie down, he comes, he wants to get the tab done. He's not 100% aware of his prognosis. We are yet to do a scan, which will be done by his oncologist after this current round of chemotherapy is over. But looking at his symptoms, I don't feel good. Now, his primary physician has not told him yet that things are not looking good. And what did he do? he told that, why don't you go and meet the gastroenterologist also to see what you can do. So this is something, now this is the second time he is gone to the gastroenterologist, and there is no constructive advice which is coming in. But nobody is ready to tell him that, things may not be looking good. We'll do our best for you. He's still in hope. So he's a person who is an elephant caretaker. He takes care of the elephants. Kerala is famous for a lot of elephants. So he's a caretaker of an elephant, and he's still thinking that within a few days he's going to become okay and he's going to go back. But when I see him, I've been following him up for the last 2 months. Every 2 weeks I'm seeing him, I'm seeing that he's becoming thinner and thinner and thinner and thinner. It's not a good sign. So obviously I'm not promising nobody's promising him anything, but at least say that, promise that we'll do our best for you. And of course, there's a lot of things to do for this person right now, which many of the things we'll be exploring as you also go through sessions. So yes, build a relationship with this person. Assessing and documenting. So there is a cause, duration, effect on sleep and functional status. These are certain basics which you have to look at. Are there any palliating factors? Are there any provocative factors? What is the quality of the pain? Is there radiation of the pain? What is the site of the pain? What is the severity? Is there any temporal association with it? Etc. So these are things which you have to, set of things which you need to inquire. So these are things which you will be looking at in detail later on. So quality of pain. We were saying that there are different qualities of pain. And this quality of pain is described in very many ways. Different languages have got different, the way people describe it is in different languages. But usually in English, these are some of the terms which we use. Pricking kind of pain, piercing kind of pain, stabbing, throbbing, gnawing, colicky pain, burning, aching, shooting, pins and needle sensation. Very common thing which we, this person who had this head and neck pain, head and neck cancer, what he said was he felt that in his ears there is somebody is holding a nail, and with a hammer he's hitting the nail again and again. That is how he's feeling when he had that facial pain. That was his description. Many times people say this thing which I described, there is a paste of chili paste is taken and being applied on raw skin. That is the kind of pain which they are feeling. So different kinds of descriptions of pain which is there. So how do you assess the severity of pain? There are verbal descriptor, like, there is no pain, there is mild, moderate, severe, or excruciating, unbearable pain. There is a numerical rating. This is the one which we very commonly use, where on a scale of 0 to 10, 10 being the worst possible pain for you, how much pain do you have? Visual analog scale, we look at faces and they have to grade their pain accordingly. There are other phases, Wong-Becker faces scale, where you look at the face and then they can tick whichever way they are feeling right now. This is also another version of a faces pain scale, different kinds of faces. So there are descriptions for it, there are numerical scales for it, there are visual scales for it. Now coming to the next part of documentation, which is a body chart. A body chart is something which is going to help you or any other physician to localize where the pain is, what is the extent of the pain, and even the severity of the pain can be described. You can use different colors to show severity. You can use different kinds of shading to show different kinds of pain. Right? So that is where body maps become useful. So you have to shade the areas of the body that hurts using different colors or shades to reflect the pain quality and its intensity. As you can see over here, black is for severe pain, blue is for moderate pain, green. This is not a set standard. This is up to you. You can have your own color coding depending on your setting. And you can see certain pains is the arrow is made. You can see the black arrow, which shows that this is sort of a radiating pain. So here there is different kinds of shading is done. Shooting pain has got the arrow, throbbing pain has got a star, aching pain has got a different pattern to it. So extremely useful body maps, so that you don't have to write long histories, just draw it on the relevant body part and the next physician gets it. Now there's another description for types of pain is, one is baseline pain. There is always a continuous pain in the background. Okay, there is always a continuous pain in the background. This is called as a baseline pain. This is a pain which the person feels most of the time. It is continuously there. In Mr. A's case, it was a continuous pain which was felt over the jaw. Then there is something called as a breakthrough pain. As the term suggests, this happens suddenly, on and off, like a breakthrough happening. Sudden, unpredictable pain. In Mr. A's case, it was a kind of neuropathic pain which was happening over the face. Mind you, head and neck is a region which is richly innervated with nerve supply. Remember sensory homunculus? Yeah, there's one guy who looks different, like looks very weird with big lips and a big head. Then his body becomes small. He's got big thumbs. Sensory homunculus. Yeah. So head and neck is a region where there is very good innervation of nerve supply. So you can imagine, and I want you to know also that head and neck diseases, cancers, etc., are severely painful, unbearably painful. So this Mr. A had got neuropathic pain on and off as breakthrough pains. Then there is incidental pain. When Mr. A tries to eat or speak, that time there was severe pain. So when he's trying to do an activity, there is severe pain. And there is end of dose pain, which means that you gave some medication, but before the medicine was active for 4 hours, and once the dose is going off, it's time for the next dose. That time there is a pain which is happening, which is called end of dose pain. So what did we do for Mr. A? How did we address his total pain and make it into total care, which is what all of us are striving to do, and which is what medical science is also trying to do. Because in definition of health is all not just the absence of physical disease, but a sense of physical, social, mental, and spiritual well-being, right? So these are the dimensions which we are looking at to address the health of this person. So in Mr. A's case, what did we do for the severe physical pain which he was having? There is something called as an opioid trial. That is, within a few minutes, we injected some opioids through him through intravenous route, repeated the dose in every few minutes, and then within half an hour, we made him completely pain-free. And something which he never imagined possible for the last few months. Just within half an hour, he was completely pain-free. So this is called as an opioid trial. We'll be looking at it in later sessions. A psychiatric consultation was facilitated to look at different aspects of his mental health, as well as for his wife, who was having an existential crisis as to how things will proceed in the future. Socioeconomic issue. Now, this is where we have a network of volunteers on the ground in the communities who are sometimes of the same locality, sometimes of a different locality. We asked Mr. A that what is one of his major concerns. And one thing which he told was he wants his children to be educated to be well educated. Already I'm finding it hard to earn. Now I'm not able to go to work. How will my children's education be taken care of? So we had somebody, a volunteer, who was willing to donate enough amount for the tuition fees of the children. And a poultry business was set up for his wife. That is, his wife is an unskilled, like she was not going for work anywhere. She was a homemaker basically. So we had to try finding something which doesn't require that much of a skilled work in the outside world. So what we did is within their home itself, we helped them set up a poultry business where not just eggs, once the poultry multiplies, they can start selling it as well and start getting income through that. So that was done for them. Both of these aspects were done through volunteers. And for a spiritual and existential crisis which he was having, the moment the pain was taken care of, we told him that definitely you can start once your symptoms are under control. You can start contributing back to your family and your society by working. In this, the other dimensions also had to be taken care of. So this is what we are trying to say, that we need to have a wholesome approach or a holistic approach to health. I'm sure many of us want to do the same, have the same approach where we can look at all the dimensions and make solutions for them. But many a times within the four walls of a hospital, it is practically not possible. So anyway, so in this situation, this is how we were able to give total care to Mr. A. So with that, we come to an end of this part. This is just an introduction to pain. And some of the takeaways which I would want you to remember is, pain is what the patient says it is. A total pain approach where you look at all dimensions of a person, because this is all interrelated. And only even if we keep ourselves as a patient and imagine, we know that this is true, that it is not just physical pain. The physical pain worsens due to many other elements which is happening around them. And what we need to do ideally is to develop a care plan which will lead to total care. Is it possible? How to do it is something which we'll look at later in the sentence. So I think we have some time for some questions or any comments, any thoughts, any feedbacks, anything at all which you have in mind. Please feel free to share. I'll just keep my eyes open at the chat box.
Thank you, Deepak. As you have said, this is an introduction to pain, and they will have few more sessions. But you've given a in-depth insight on the introduction for them to have an idea and move forward from there. And as you've said, they could either type or unmute and speak also. Either way is fine with their queries.
Thank you, ma'am. I'm all ears for the next couple of minutes at least.
That's all. Maybe you could come out of the presentation and we can see all of them, and so that if anyone has any queries, and on top of that, then we can see what is that.
How to deal with socioeconomic pain when we are working in a private chamber? Yes. Yes, we'll look at it. Dr. Bhargav. What is the unit of measurement? There is no unit as such. It is just a very subjective description. Many times when you say, that's why we many times use the numerical scale. There is no unit as such, but it is just that how bad it is for them. Sometimes the only question I ask is your sleep getting affected because of the pain? They may not be able to describe that well, but they may just ask, I may just ask them that, is your sleep getting disturbed? And if they say yes, That means the pain is so bad that they're not even able to sleep. Then you don't need a description beyond that. You will start medications accordingly. So Dr. Bhargav, about socioeconomic circumstances, how you can address them is, this is where the importance of partnerships comes. Always, there is somebody or there is an organization or a group of people who are out there in the community who want to do good. They have the means to do it. Maybe they don't know whom they want to give it to. Or sometimes they know who needs it, but we don't know who is the one who is providing it or who will be able to provide that care. So this is a case where we need to have partnerships with community-based organizations, even private sector organizations. So ours is an organization, we are a charitable trust and an NGO who works primarily in the community. But we have hospitals, private hospitals, who have collaborated with us, who will tell us that, you know what, we have a patient, this is the issue, this is where he lives. Can you send your team to their community and find out what can be done for them? So the curative part of the treatment is happening in the hospital. But when we go, we have a team and we spend at least 30 to 40 minutes. Whenever there is a new registration which needs to be done, at least 30 to 40 minutes we spend with them. It is a multidisciplinary team because we look at different dimensions, right? So there is a doctor, there is a nurse, there is a social worker, and more importantly, or most importantly, there is a volunteer. This volunteer is somebody who is from the locality and he knows people in the locality. So many a times it is him or her who tells us who will be the right person to provide care. Sometimes it may be the person doesn't know where the next meal is supposed to come from. So we go speak to the neighbors and ask them, can you cook one meal per day and give? Sometimes it is they require some funding for buying medications. So this volunteer will develop a network of people, well-meaning individuals who are willing to fund for the medicine. Sometimes it is just to assist the person to go to the hospital. You know, many a times he's taking treatment from a government hospital, doesn't require much money, but doesn't have enough money to reach the hospital. Because of severe pain, is not able to use public transport or bus, needs to call a taxi and go. We have many people over here. The tertiary care center over here is 60 kilometers away from the locality where we are serving. So this person, every time he wants to go and meet a specialist primary care physician, he needs to hire a taxi. To go and come, it takes 3,000 rupees to go and come. Who pays for this? This is a socio-economic issue. So this is where a network of volunteers, community volunteers, well-meaning individuals who are there. And many a times these are people who are retired and who are looking at something they want to contribute to society. That is one extreme. The other side is there are a lot of student groups, you know, of different colleges who come together for a cause. We have situations over here where we entrust the remodeling of a house. A very poor person whose house, because of indoor air pollution and indoor cooking and everything, the walls have become black, neglected surroundings, etc. And we entrust a group of students as a social initiative to go and clean up the house, paint the walls, you know, simple things which can make life better for a patient. And just that change in atmosphere makes him feel better. In Mr. A's case, one of his major pain points was my children's education. We have had cases, this was not in Mr. A's case, a different case where some other cancer was there, severe pain. We are giving medications and giving him opioids, hiking the dose, and the pain is not settling. Finally, we asked him, what is the one reason which is causing you maximum agony, maximum pain? And he said the same thing, my children's education needs to be taken care of. It took a few days, but we were able to find a sponsor till 12th standard. He will take care of the education till 12th standard. Once that happened, the moment that happened, that time onwards his pain started reducing to such an extent that we brought down the dose of morphine as well. So this is a very tangible, sense of how much impact non-physical factors or non-physical dimensions can have over the physical dimension of pain. Dr. Madhu, in case the patient has coexisting renal failure, yes, we need to look at, so renal nepropalliative care is a major upcoming subspecialty in palliative care itself. There is something called as conservative kidney management. I'm not sure if we'll be having sessions on it, but there is something called as conservative kidney management. I think this year the IAPC has launched a course also on conservative kidney management. I'm not sure if it is IAPC or another body, palliative care body, but in this year it was launched in India last month in Bangalore during the conference, palliative care conference. So we have to look at the cause of the renal failure. And one of the first principles of palliative care is correct the correctable. There is a perception that palliative care means when nothing else can be done, you go to a palliative care person, which is absolutely not true. Even in palliative care, the first principle is you always correct the correctable. That means you have a curative approach in your mind and you explore all options. This is why good knowledge is also important. You need to look at what are the possible factors, and this is also a multidisciplinary approach. We have specialist and super specialist doctors who have been trained in palliative care, who are just a phone call away for us, for our patients. So before we take a different route, we always try going active. We call up the specialist or super specialist, discuss the case with them, get inputs from them, and then try following that route. Right? So correcting the correctable. So yes, renal failure, it needs to be looked at what the causes are, and then we need to advise or take the patient in the journey accordingly. And these are not things which we do in one sitting. We have to understand what is called as the insight of the patient. What do you understand of the disease? What have the other doctors told you till now? Looking at your symptoms, how do you feel that things are progressing? So that's how it is. So it sometimes takes multiple sessions, or at least some time to get the patient on board. Which are the pain relievers used in cancer pain? Yes, we'll be looking at it. There is something called as a WHO pain ladder. There is a step 1, there is a step 2, and a step 3. First, usually we start with step 1, which is non-opioids and certain additional adjuvant medications. There is step 2, in which we use weak opioids. And there is a step 3, in which we use strong opioids. So there is a pattern to it, how you start medications. And all these 3 categories have got different generic medicines under it. So there is a separate session for it. We'll be going through it in detail. Yes, more questions?
I have one query.
Hi, sir. Please tell me.
So pain is a very subjective. Pain is very subjective nature, and as we are discussing, and when we are talking about palliative care, we know that there is a definitive organic serious illness already going on.
Yes.
So, but as you yourself narrate that one scenario where their pain subsides after the economical part was taken care of, but some patient may be having a real pain which is not relieved by the whatever pain reliever, and
Yes.
is the actual pain. Another may be that it is the other components, the mental component, emotional, which is causing that pain. But
Yes.
it's very difficult to differentiate these two. So is there an easy way to differentiate these two? Because otherwise, in other scenario, if it were not a palliative care patient type where they have simple complaint, we can think of the other thing, the organic things may not be there. Or here too, we have a definitive, very significant organic problems already there.
Yes. So, sir, in one way, this is what we need to change the approach also, is that we need to look at all the issues which is causing pain, and sometimes you may not be able to associate it with an exact non-physical cause. Okay, even the patient may not associate it. See how many times the patient will tell their home issues to you. They will tell that you give me the medicine, because they also sometimes don't have the understanding, or many a times they also don't have the understanding that this is a multi-dimensional thing. But our job is, even those other non-physical dimensions of pain, we want to find them out. And even if the patient is not demanding that this needs to be taken care of, those are things you are willing to provide solutions to. Okay. And somewhere in those non-physical dimensions, the pain also, once you start addressing them, the pain also starts reducing. And as far as the pain is concerned, we have very strong medications and different modalities of approaching pain. Giving medications orally and parenterally is just one type of it, one form of approach. There is also interventional pain. Interventional pain management, I think you will be having sessions on it also. You'll be having a session on interventional pain management also. So there is a lot of things to explore.
1 minute, Deepak, for him, no? Like first, just to answer his query, the definition itself is an answer. What was shown, no? That what is this
IASP, yeah.
International Association's definition itself has all these components. So physical, emotional, sensory, and potential. There could be a real damage or a potential damage. So all components together only make pain. That is why it is complex.
Yeah.
So I understand your query. The root cause or whatever is the cause for the problem will also be dealt with. Plus, you have to have all this in mind. So when you're dealing with the other potential causes like social, economic, then you are going to deal with the primary problem also. So when you deal in total only, you will get a good relief. So that is what, not that the main problem will not be considered. So there are medications, and as you have been mentioned, you have at least 2 or 3 sessions on pain, on how to manage normal pain, WHO ladder, and there's a session for difficult pain management also. When something is not relieved, what happens? There you will have other options of management. Interventional management also is there. You will be dealt at least 2 or 3 sessions you will have on pain.
Yes, Dr. Anupama, very true. There is psychosomatic pain has implications on pain pathways and treatment. Yes, psychosomatic pain is also something which is absolutely a reality. There is no question, there is no dispute on it. And many a times this is where a multidisciplinary team, once we think that things are not working out, and we have a clinical psychologist with us who works with us, who tries exploring things and things are not working out positively, we do get a psychiatrist also. There is the medical college over here. He sends his residents to us, public-private partnership. It's a government hospital, but then they send their residents to us. They have a look at do a detailed assessment of the case, go back to their professor, and then he calls and lets us know that there are other elements to it which we have not been exploring or which needs to be explored. These are the medications which you can start off, and we follow what they have to say.
So it will be a multidisciplinary approach and multimodal management. Multidisciplinary approach is done to aid with the diagnosis and things. Means social, psychological, all other elements are covered through the multimodal management to obtain an overall complete relief.
Yes, Dr. Amulya, it's surprising that there is so much amount of pain relief when the socio-economic or psychological component has been addressed with. Yes, majority of the times, things get worse for us only because of lot of other factors which is there around us and inside us, right? And all of this it's an ecosystem which is at fault most of the time. So many things needs addressing. We are trained to do one thing, our hands are tied because of the kind of circumstances in which we work in. It is not always possible within a hospital where you can address all these issues. This is why you need to have a multidisciplinary team, you need to have a social worker. You can even explore how students can get involved in this, because I remember that when during undergraduate days, many a times during rounds they will talk one thing. There is the main doctor and the PGs are there, then the UGs are there, and then it's just a commotion which is happening over there. In between, the doctor speaks for 2-3 minutes and goes. And after some time, the caregiver comes and asks us, "What did he say? What is it finally? Can you tell me in simple terms?" So even that explanation which that undergraduate student may provide is a big sense of, okay, fine, now I understand. Is a sense of solace. It has a bearing on a lot of factors which probably we undervalue. Ma'am, I think can we go to the case? We have a case
Exactly.
presentation also.
Yes, that's what
Yeah,
I was also
we have
thinking. We'll
about
do the
20
case
minutes
presentation and come back.
and come back. Yes. Can we minimize the chat box? All right.
Actually, hi, Sripriya this said. Actually, Dr. Prakash has conveyed in the morning that he might not be able to read through the complete case because
All
he
right.
is having throat infection. So I'm taking the privilege to read through, and I believe that Dr. Prakash is available in the meeting, and he will be ready to take up further queries which will be coming.
All right. Dr. Prakash, are you here? Yeah. Yes. Hi, sir. Yes. So you want to take up going through the case?
No, sir, it will be better.
It will be better. All right. All right.
Anu, we can move to the next slide.
Please continue.
No, okay. This is a 61-year-old male with the diagnosis of cancer lung. And in the next slide, the presenting complaints are pain in right side chest for 1 year, disturbed sleep for 1 year, and decreased appetite for 3 months. History of illness, the patient had right-sided chest pain 1 year before, and he was diagnosed to be suffering from cancer lung in a government hospital. Since then, he was treated with chemotherapy and radiotherapy. The pain was insidious in onset and non-radiating in nature initially. Later on, there was a history of radiating pain downwards, which was on and off. The pain was relieved with medications, but not completely, aggravated while bending down. Sleep was reduced and disturbed due to pain for the past 1 year. Appetite decreased for the past 3 months. His bladder habits were normal. History of constipation on and off, and there is no history of breathlessness or dyspnea. On examination, the patient was conscious oriented, thin built, poorly nourished, no pallor, icterus, clubbing, cyanosis, lymphadenopathy, and the systematic examination participants can see in the slides itself. BP was 136/86. Moving on. Can we have the next slide, please? Okay, the treatment and significant investigation. The present treatment is tablet tramadol 50 mg TID for 3 months. The previous treatments, radiotherapy 5 times, chemotherapy 6 cycles. There was no surgery performed. The recent investigation figures are given in the slide for everyone to refer. CT thorax 10 months before done showed a malignant neoplasm involving middle lobe and posterior segment of right upper lobe with adjacent chest wall invasion, metastatic lesion in right apical segment, and calcified granuloma in right lower lobe. Did we skip a slide in between English? Okay, next slide, please. Psychosocial aspects, it is a 61-year-old married man living with his 56-year-old wife. He has 1 daughter and 2 sons. The daughter is married and living separately. Elder son is married and having a young child. The younger son is yet to be married. He is a manual laborer and currently not working. So current medications, tablet tramadol 50 mg TID. The main concern of a patient here is pain. To summarize, we have a 61-year-old man with carcinoma lung with pain over the right side of the chest, disturbed sleep, and constipation. So the discussion points are: how can the patient's pain be relieved? What can be done to improve the quality of life of the patient? So Dr. Radha and Dr. Deepak, it is over to you.
So, Dr. Prakash, what was the curative treatment plan for this person? Is it available to us? Like the more cycles of chemo or radiation, is it pending? What is the status of the disease? Has it become better? Anything you want to fill in with us?
No, sir, there was no plan for any curative surgery for this patient.
So still continuing chemotherapy and radiotherapy?
Yes, sir.
Okay. And how bad was the pain for this person? Like he hasn't slept at all for 1 year?
Past 3 months, he was not able to sleep. That was the history given by the patient.
Okay. And how long has it been since he was on tramadol?
For past 3 months, he has been taking tramadol.
Okay. Were you the one who prescribed him tramadol, or was it some other physician?
No, sir, it was like not by me. It was other
Okay.
by other physicians.
Okay, so there is so he was not able to get satisfactory pain relief with this, basically.
Yes, sir.
Okay, and probably the dose was titrated, like it was one way, maybe started once in a day or twice in a day. Now he is taking it 3 times in a day.
Yes, sir.
All right, all right. So how would you want to approach this person, Dr. Prakash?
So maybe morphine could be tried, sir, for this patient.
All right. So there is always, so like we were saying that there are different medications. Tramadol is something which we call as a weak opioid, not powerful enough. So there is a higher level to it, which is called as a drug called morphine, which is one of the strongest opioids which we have with us. So morphine can be tried. Yes. What can be done to improve the quality of life is for this person. What all did you think of?
So
Okay,
he is
let's look at this.
concerned of-
What all are the things which you will be concerned in this person?
So he would also be having a guilt feeling due to his past 40 years of smoking habit and alcohol habit. So that guilt has to be removed. I mean, he has to be told that. It
How
has
do you
happened.
plan to do that?
Some counseling sessions has to be arranged.
Okay, Dr. Anupama is here. Dr. Anupama, do you want to help Dr. Prakash out? This person is feeling guilty about being a smoker in the past. He's got lung cancer now. He's in very severe pain.
Yes, sir. I think we can do something about the guilt. It can be addressed. Also, we might have to look into a little detailed assessment as to not just the guilt part. Maybe he is having underlying mood symptoms or anything else also needs to be looked into. Because sleep disturbance, it is also because of the pain, but over a period of time, as we are treating patients, we have also seen that the emotional component adds to the pain because it's the
Yes.
same pathway, sir. Serotonergic and noradrenergic systems. The central pain pathways, it's the same pathways. So especially the norepinephrine. So they do respond to a smaller dose of what we call a serotonergic noradrenergic reuptake inhibitor, SNRI also.
Okay.
That we have tried as an add-on because more than most of the private setups are a little stringent on the use of schedule X drugs like morphine.
All right.
So we have added to these people suffering from cancer, especially I think more than in my share, only 4 years of experience, I will first tell that. So in our experience, we've seen, I think, only 2 cases, and one of it was bone pain because of metastasis. So that
Okay.
kind of pain does not 100% respond to medications, I guess. But
Yes.
we did have our try.
All right. All right. So there is more deeper elements which needs to be looked at.
Yes,
You have to,
yes, he
you
will
have to look at
definitely
mood
need a
swings
complete
also. You have to look at
consultation.
guilt. Yes. Let me ask everyone in a very common, with the knowledge which we have, do 100% of the smokers get cancer? I don't know the exact percentages, but I'm sure that not 100% of smokers get
No,
cancer.
if I
right?
can speak, actually, my patients come to me with statistics. They tell me, they quote studies and say that, see, ma'am,
Yeah.
everyone, when I advise them to stop smoking, they say not everyone who smokes gets cancer.
Yeah.
So,
Yeah. Yeah. So this is one thing is that, patients do feel guilty. But one of the aspects is it is not really, we don't know if it is only because of the smoking. Yes, it increases the chances, But then there are certain factors which is out of our hands. And no matter how much ever we would have tried, probably it is possible that we may still end up getting a disease. We are not sure of it. That is one of the ways in which you can try. You cannot decrease it completely because the patient comes with a hard head that this is the reason why this has happened. But you can try easing it for them a little bit. The other thing what I would be concerned in this person is he's a daily wage laborer. That was mentioned. He's a daily wage laborer. He's got one more child, so one son who is still dependent on him. So probably mechanisms of I would want to explore that how much of a concern it is for him to secure this son's future, so that there is and for his wife also, that how the income is going to come in the family, from where it is going to come. Is there a mechanism for it? Do they have any family support system? Many a times we see that once a family member gets a disease, other family members take care till the time it is convenient. Mind you, this is very common. But beyond a point, they just try washing their hands off, to put it very simply. I don't find fault with them. There are restrictions to what a person can do. But many a times, the family members also start neglecting just because there is not enough to share. Enough care to share, there is not enough money to share, there is not enough food to share, there is not enough space to share at home. These are some of the realities which we get to see. So I would be concerned, mighty concerned in this person who is an elderly person. Okay, there is a potential he may end up being a burden to the family. His pain is not controlled. He is a daily wage laborer, not earning anymore. Who is going to take care of him, and what is the mechanism in place for him to be taken care of? These are certain things which I would want to explore to see how I can improve the quality of life of this person. Dr. Prakash, do we have any information about that? There is some other family member who is supporting, or some other source of income which is coming in, anything like that? Are we aware of it?
Sir, currently his elder son is bringing him to the hospital. But as you said, sir, I don't know how long he will be taking care of him.
Yeah. So these are certain conversations which we don't necessarily have in front of the patient himself. We have the nurse who takes care of certain things, right? Like checking the blood pressure and things like that. So when that is, we say that, okay, let's have a look at you, and then hand over to the nurse. And in the meanwhile, you have a conversation with the son or the caregiver who is bringing them in. So make some space, make some time somehow to talk with the caregiver, and then explore things with them. Many a times the caregiver also want to do something, but they're not sure whether they can show their helplessness to a doctor. Many times they don't show it. So these are certain situations where we need to probe a little bit more, allow them to open up a little bit more, and see what we can do about it. Anything else, sir, you want to add regarding this? Like what is his current status right now? Is this a patient whom you are still on follow-up with, or you still have access to?
So we took the history, and it was handed over. The patient was referred to an NGO in Pondicherry here, sir.
Okay.
And only under their follow-up.
Okay, probably it will be worthwhile for you to find out what has happened to this person after that. What were the mechanisms in place? I don't know, probably if things are being done well with that NGO, you may use this as an opportunity to present the work that NGO does to your organization or your hospital, and make sure a partnership develops. This is how it starts off. This is all it takes to start off also. Little unconventional maybe sometimes you may feel, but then this goes a long way in making sure that the end beneficiary is taken care of. Radha ma'am, do you want to add something? Or yes, ma'am.
I was just thinking the main couple of things, as you said, overall assessment has to be done. Okay, because that is what will help us. And then for him, it was mentioned that sleep. See, their adjuvants will have a role, and that will be dealt with when you go and deal with WHO ladder, it will be mentioned, because they also help. Because for him, no, like even if he gets one proper sleep, 1 day sleep, then he will know how much relief it brings to him. So like that, dealing total pain is what I wanted to convey. And one more thing from the beginning, what was in my mind was to act as a link. See, you have someone who needs help, who is coming to you. And there may be someone, there are many organizations, there are groups, support groups, so many things are available now, because they're all waiting. There are many organizations or individuals waiting to help. They don't know whom to help. So you could just be a link. So this is slightly more than what is possible, or more than what you think, but it does help in a very big way. And the person who needs it finds, because on the other end, one end, demand supply, both are there. Finding and making a link between the two will be very helpful, and it does work. Many places it is available. Even in private, I would say there are many organizations who are willing to. Maybe as a private person, you may have to add on some more contacts. And as Dr. Deepak was mentioning, yes, it is slightly more than the norm, but it will be helpful.
So do the other doctors over here want to ask something or contribute something? Yes, Dr. Brojan, you have raised your hand. Can you please unmute? Yeah.
No, I just wanted to know, in India, do we have this patient support system, especially in cancer? And which
Yes.
states is working very good in that way?
See, I have to say that this is the distribution is not equal or equitable. Okay. I can be proud in saying that Kerala is one of the first states who developed something called as neighborhood networks in palliative care, which is every neighborhood has a network in palliative care. There used to be a place in Kerala, in the northern part of Kerala, where every household will have at least one volunteer. Okay, it has been like mass movements also, where every private bus driver, they donate 1 rupee every time they enter and leave the main bus station. So there are like 150 buses. They enter and exit the main bus station like 10-15 times a day. So they earn anywhere between, that the box earns anywhere between 1,000 to 2,000, 3,000 rupees a day. And just in a month, they collect enough money to donate. So what I'm saying is, support systems is something which develops once the community takes ownership. And community taking ownership is something which can be approached in different ways. Here, how it was developed is, there were a few good meaning individuals who came together. But now we have a lot of other opportunities. If you are working in a medical college, there is a community medicine department over there. From there, their major work is on the field, right? So they are the ones who develop partnerships. Same way, there are organizations who are not core palliative care, but then they help the disabled. There are organizations who look specifically into women empowerment. There are organizations who specifically look only into cancer, only look into stroke and disabilities, etc. N number. There are lakhs of NGOs in the country. So there are N number of organizations. Now, these are all elements which needs to get connected somewhere. Because depending on the illness of a person, their needs are different. And different organizations may be able to cater to different aspects. There are some organizations who do work only for the elderly, right? Alleviating isolation, loneliness of the elderly, Help Age India, etc. They help in different ways. There are different organizations depending on the state. There are religious organizations. A very major part of the support system is religious organizations. Tapping in their potential to reach out to people in the field is something which we should explore doing. We don't have tie-ups as such, but then we have referrals which we get through religious organizations as well, where we get connected. So this is something which you need to look at in your state. Where are you coming from? If you could tell me where you're
from
based.
Manipur. It's Manipur.
Manipur, okay. So we have a Northeast coordination team. We have a zonal in charge over there. Probably he'll be one person whom you will be, I can connect you to with him, and probably you can explore what are the associations which palliative care has in that region.
Okay, that would be great.
Sure. So as
Thank
the
you.
sessions progress, do keep this in mind and get in touch with us. We'll connect you to the person.
Okay, fine. Thank you.
We do have a section on how to develop and start services also. In that session, you will have one of our HR team also in it. And when we will give information on all the 4 zonal contact people whom we have. And always you can get in touch with Pallium to help, to guide you to get in touch with those regional coordinators and then move forward from there.
Okay, thank you.
Yes, the other doctors, if you want to contribute towards the management of the case which was presented, any doubts which you want to ask? Dr. Prakash is still with us. All right, all of us staring at the screen at each other. I think if that is all, then if you want to give some comments or feedbacks, you can please feel free to post on the chat box. We have a couple of minutes more. Ma'am, over to you, ma'am.
Exactly. The thing is that thank you for both Dr. Deepak and Dr. Prakash. See, these sessions mainly are interactive sessions. You all have the opportunity to discuss, bring forth your queries and get them clarified as much as possible, because only then will help you when you start practicing in all forms. So having an interactive session is what is very important, and that's how these sessions are normally. And even today, see, so many things came up, and feel free to raise your queries, and then that will be helpful for you. And please do fill in the feedback forms also, because so that will help us to keep on improving the sessions every time.
Especially if there is something negative comments from
Yes,
your
please.
end, please feel free to share it, because those are the
Both.
things which is going to help us, to fill in those gaps which is there. So
Both
feel free
positive
to
and
put your
negative.
comments. Yes, ma'am. Yes.
Yes, feel free. That's what, because that is what it is. To keep on improving. Improvement is what brings perfection finally. Okay, then in that case, we'll hand over to Sri Priya to.
Thank you, ma'am. Just adding on to that feedback part, just informing that whatever feedback you'll be giving is anonymous. Even we will not be able to know who has said what. So please be honest with your feedbacks. So thank you, Dr. Deepak. I know you might have had a very tiring day, because I have been seeing you most of the days, and all your days are so tiring. You are such a multitasking personality. Thank you so much for joining us and enlightening us on the concept of pain. And thank you everyone for joining and making the sessions interactive, with a promise that we'll be meeting again. Sorry for that. We'll be meeting again with another interesting topic and yet another eminent faculty. This is Sri Priya, along with Dr. Radha Venkatesan and Dr. Deepak Sudhakaran, signing off from the Tips Echo Hub. See you in the next session. Till then, everyone, take care. Keep spreading happiness. Bye-bye.
Thank you. Thank you, Sri Priya. Good evening to all of you.